Davis, CEO of the World Affairs Council of Harrisburg, and to really discuss a very fulfilling content of state of Black health. It is Black History Month. Diversity, equity, inclusion is so important to Highmark, part of our core values. So to not just be able to participate, but to actually be able to host, engage, more meaningful way is very important to us. So we're really excited about the event. I'm going to turn it over to Joyce to set up the agenda and the speakers. And thank you again for participating.
Thank you so much, Joe. And thank you so much, Kathleen and Leyland and all the people at Highmark who have been so supportive of our efforts with the World Affairs Council of Harrisburg to inform our community about health issues, about public health issues. You know, during the COVID pandemic, we knew that we couldn't wait again until there was a crisis to make sure people trusted the information we were giving them and that they were educated on public health issues. And so that's why we are dedicated. We now have a public health initiative as part of the World Affairs Council so that we will regularly bring experts, people who know what they're talking about, to our community that are trustworthy. So that's what we're here today to do. This is one of our highlight events now. This is the second, and it will be annual State of Black Health Forum. And we have assembled some people here, some experts who are going to be able to give you an overview of just where things stand with regard to the top issues and of course in the disparities that exist. But before we go on, I just want to tell you the World Affairs Council of Harrisburg was founded here in 2010. We have a vibrant board of directors. We are a part of the World Affairs Councils of America, and we actively participate not only in this, but in many other forums dealing with international, local, and national affairs. Because, you know, while other councils may only have dinners with ambassadors, we're about really being with the people. All right. So before we get started, though, and we go into there's a lady here that I want to give just 2 minutes so that she can tell you about a special project she has in our community. Terry, would you come up and just tell them about your project, enlist their support, and then we're going to step into our forum. You want to come up here? Okay.
Thank you very much, Dr. Davis. This quickly, I'm a member of the Susquehanna Art Museum, but I am a museum professional, actually, and one day we can talk about all the things that I've done. But what we're doing at the Susquehanna Art Museum is something a little unique. We're trying to collect the stories of people who collect, because these are the memories that people have and things around them. And those memories inform how people collect things and how they look at things. And in that process, we're collecting stories. Right now, we're edging up on about 20 different stories, from everything from people who collect Oriental rugs to people who collect boxes and pens and a variety of things. And even in my own world, I collect fine art, but I bet you I collect some things that some of the women in here collect. I collect dolls. I had, Barbie dolls and this kind of dolls. And also, those are the things that were part of our memories or that connote memories in us. So I'm going to leave a flyer in the back, and you could do this until April 1st. All we need are 250 words on why you collect, what is your memories and your inspirations about collecting, and 1 or 2 pictures. And we're going to assemble this. And when the Susquehanna Art Museum opens its exhibit in June called Memories and Inspirations from the Davises, which is the Davises of 2 African-American people who are couples in Atlanta who have African-American art. So that's what inspired all of this. So I hope you will join us and come up with your 250 words and that picture about why you collect. So thank you.
You're welcome. Thank you, Terry. I wanted to give her an opportunity to get the word out. And I wonder who collects those Oriental carpets. I wonder who that is. Anyway, let's now move into our discussion today on the state of Black Health 2024. We have with us Dr. Thomas Butler. He is a board certified, fellowship trained abdominal transplant hepatobiliary and robotic surgeon. I hope I said that close to right. He earned his medical degree from Southern Illinois University School of Medicine. After completing his residency in general surgery at Eastern Virginia Medical School, he pursued abdominal transplant and hepatobiliary surgery with fellowship training at the University of California, Los Angeles. We also have with us Dr. Sharee Livingston. She specializes in obstetrics and gynecology and is board certified by the American Board of Obstetrics and Gynecology. She practices at UPMC Obstetrics and Gynecology Specialists, Lidditz, and is affiliated with UPMC Harrisburg. She is completed her medical education at the Philadelphia College of Osteopathic Medicine. She completed a residency at Pennsylvania State University College of Medicine. We also have with us Colonel Jim Williams, a prostate cancer survivor since 1991. He boasts over 27 years of advocacy. He's retired from a 25-year Army career. He served 15 years as Human Resources Administrator and holds the Senior Professional in Human Resources designation. As principal of Jim Williams and Associates, a prostate cancer focusing consulting firm, he leads in awareness, education, and advocacy. He is well known in our community. I can't even begin to tell you that this is someone we really want to hear from. And finally, we have Ronnessa Edwards. She is a passionate advocate for human rights and equitable access to mental health services. She began her impactful career as a behavioral specialist and youth studies counselor, providing mentorship to Black and Brown LGBTQ plus youth in nonprofit and juvenile detention settings. Since 2006, Ronnessa has held diverse roles in Pennsylvania state government and currently serves as Pennsylvania State Government Human Relations Commission and serving as a specialist in mental health and wellness. She supervises civil rights investigations and conducts trainings on implicit bias, discrimination, and diversity for both public and private sectors. So you see, we have a diverse panel that are bringing different perspectives. So why don't we just jump right into it? I'm going to turn this podium over to Dr. Butler for him to begin our discussion.
Good evening. Good evening. There we go. I'm going to advance this, right? Well, welcome to everyone. Although I don't know a lot of you, I hope during this conversation you grow to trust us as a panel. The goal here is really just to educate and to answer questions that you have, because this needs to be a spark that lights up the entire community. There aren't enough people in here for us to totally move the needle in Harrisburg, but I think with a small spark, that's how things sort of progress. Perfect. So the only disclosure I have is that I don't do this for money. I do this for a deep love for my community, a deep sense that my community should do better. I wanted to do better. I'm from the South Side of Chicago, and that's why I do these things. This picture is really something that happened to me during COVID. I mean, all of us probably fought some COVID battles, so to speak, when we were trying to convince the world that COVID was a thing, and then trying to convince our community to be vaccinated was an uphill battle. And it takes a toll. It takes a toll. One of the physicians that was on this panel with me actually committed suicide after being dragged on the internet. Really went viral. We're on stage with some pretty famous and popular people, and people don't know their power. And this young lady committed suicide. So I hope that no matter what, you guys are kind to others, because it does take a toll. So I was not going to do a PowerPoint, but I sort of searched through some of my old PowerPoints and I found this. And as you can see the date, it's 2005. I was still in medical school. what's the title? The State of the Black Male. And here I am 20 years later, getting ready to talk to you guys about the same topics. I thought that was profound. So I'm going to go back in time a little bit to tell you what was the state almost 20 years ago when I was just a young MS4. So here are the statistics back then. 25% more Black males in jail than college, 41% of all inmates African-American, a third of those ninth graders didn't finish. Leading cause of death between 15 and 24-year-olds between African-American males was violence, a third of the new cases of HIV, and we only made up 12% of the population at that point. That's 20 years ago. So at that point, we had about a 1.6 time more likely to have diabetes than non-Hispanic whites. 25% of African Americans between the ages of 65 and 74 had diabetes. 1 in 4 African American women over 55 had diabetes. And diabetes and hypertension were the leading causes of CKD. The causes are multifactorial, and we can't dive into that boat in the hour or 2 hours that we have, but systemic racism can be the answer for everything, and we can dive into why, but or you can go as far as even the science of systemic racism and talk about the epigenetics or the trauma that's embedded in our DNA that makes us hypertensive. So I'm a transplant surgeon. Let me sort of start to bring you into a transplant surgeon's view. So as a Black transplant surgeon, I'm very aware of some of the disparities that are in my field and specialty. We are less likely to receive evaluation. That means that your nephrologist knows you're on dialysis, you're in his chair. And if you're Black, you are less likely to receive a referral or even hear information that I exist as a transplant surgeon. There are barriers that exist all throughout the process, whether it's insurance or you talk about some of the food deserts, or you talk about like even having access to Penn State Hershey. They're everywhere throughout the process. And we know that even if you're on the list, you're listed, you're less likely to receive a transplant once you're on the list, controlling for all other variables. And that is multifactorial. You survive less if you're Black on the list while you're waiting for that transplantation. And we recently, just this year, have changed race as being a factor in what's called glomerular filtration rates. What that means is that before last year, we would calculate what's called your GFR. We'd say what your kidney function is. And then we put on a variable based on your race, and that variable would change your number. Why does that matter? Because the number would change to saying you were better than you actually were. That was based on a bunch of flawed data that basically said that we as African Americans, Blacks, had more muscle mass, very flawed old data. And so what it did was allow Blacks or African Americans to see me less often. So they would not see me when they needed to because they were too well. They were falsely elevated. So they went years of going without seeing a transplant surgeon because of this flawed data. We just changed that in medicine. And so I always like to put a snapshot of this group text up to give you an idea of the fight that we fight sort of as being Black in medicine. And this is a group text with pretty much all the Black transplant surgeons in abdominal surgery. It's one group text. So that lets you know sort of the scope of how many people and how the type of conversations that we're having to try to move the needle. So there's a paradox. I bet if I asked anyone in this room right now, what do you think about transplant? Is you know, if I have a little 6-year-old boy who needs a heart transplant, you for it? You're probably going to say yes, right? The paradox is this. There's over 100,000 people waiting for a transplant as we speak, 130,000 people. By the time I'm done giving this speech, 2 people will have died. 1 person will have been added to the list. Over 95% of Americans here feel the way you do, that transplant is a good thing, but only for 50% of people are donors. And it's, again, multifactorial. Only 3 in 1,000 people die in a way that we can actually use the organs in order to move people towards transplantation. So it's not a frequent thing. So it leads to a bottleneck and a shortage of organs. And so we know that Blacks are overrepresented on that transplant list. What does that mean? That means that although we're now 13% of the population, we are 35% of the people that are on dialysis. And the treatment for people on dialysis is a kidney transplantation. So that means that, and we are overrepresented on the list and underrepresented on the list to donate. And we'll get into sort of some of the factoids. The Black people get that off your ID. It's just, if you're on Instagram, you'll find it all day long. And back probably 10 years ago when I was, more calm, I could get into these deep arguments with people on the internet, and I've learned not to do that anymore. So I don't jump into hours of trying to convince people why donation is a good thing. And we know that people have a reaction towards transplantation, that a visceral one that's either really good or really bad. Usually if I say, hey, someone's on dialysis, I have a kidney for you, is that a good thing? People say yes. But the minute that I mention, by the way, we have to take that kidney from someone who is deceased, are you okay with that? It's a different feeling. But there's a paradox because you can't have one without the other. And so the picture on the bottom is actually a picture of some of the misinformation that we fight in transplantation. And some of you guys probably remember the story of Jelani Day. There was a lot of misinformation about how people stole his organs. And I had a conversation with Jelani Day's family, and I still was unable to convince people that this was not an incidence of someone stealing Jelani Day's organs. So it doesn't matter if you come with facts. It's a matter of people feel how they feel, and all we can do is try to put the information out, and hopefully people will understand and move the needle. So there's a crisis right now in medicine. There's a crisis in America. I mean, I don't have to tell you guys that. It seems like just yesterday when I was kneeling for George Floyd and we were talking about everyone coming together, this was me kneeling right next to the place where King went to seminary. And we were all, it was the kumbaya moment, right? And we thought change were coming, and it did. And then came a backlash, right? And nowadays, you can't even say the word diversity in some circles. It's become a political hot button and hot topic. But we know, if you look at any Pew study, diversity helps. This organization, the room that you're in, Highmark, believes in diversity, which is why I'm here. But there are some organizations that do not feel that way and do not know sort of the things that we have to fight, the uphill battle, if you will. As you know, the SCOTUS took and they don't believe that diversity is important either. They recently ruled against affirmative action. So this is an uphill battle that we've been fighting. How many people know this group? I'm looking at the crowd. I bet you at least one of you guys can tell me the group. There you go. There you go. There you go. So in 1978, I wasn't born yet, but women were just allowed to be into the Army. They were just allowed to be in the regular Army. They had just ruled that you could brew beer at your house. The Jonestown mass murders happened, and this group was number 6 or number 7. They were once, twice. Thank you. And for the younger people in the audience, that's Lionel Richie. He was the lead singer for there. There's a little music history for you. But the reason why I put this up is because there were more African-American males that matriculated that year than did in 2014. Let's say it one more time. More African-American males matriculated in 1978, 3 times a lady, than 2014. So we've gone backwards as far as trying to fight the fight in diversity. So what have I done personally? What is the fight that I fight? So I try to do what's called reach back and pull. I know where I've come from. I know the battles that I've had to fight. And so I try to start very young with children and let them know that STEM is important and try to get them to be me. When I'm 80 or 90, God willing, then I hope that, one of the children that takes care of me is someone that has listened to me and is now on the right path. This is a picture of one of the camps that I did, one of the STEM camps. I wrote a grant, got money. This all takes money, by the way. Thank you, Highmark. And basically I brought, almost 50 children from the Philadelphia area and gave them a week of STEM. I gave them white coats. I called them doctor. I let them dissect things. And the way these kids lit up was amazing. And so there's a group that does this here at Penn State. And so I came and I did not have the ability to do the same thing initially, but you can see I'm on the same path trying to reach back and pull. So I'll stop there and I'll welcome any questions at the end.
Well, that was profound. Thank you. We're going to take questions at the end. Okay. All right, go ahead. You're burning to do it. So go. Go ahead. Take the microphone. Go ahead.
First of all, I can tell you that part of the reason the EGFR is Kidney Foundation of Central PA, and I can tell you that part of the EGFR changed was because Black medical students started looking at the data and said, does this make sense? Does this really make sense? And so they started the question that finally made it up to the National Kidney Foundation, to other foundations, and we would tell our patients, look at your bills, talk to your doctor if they're still having a lab report for African American, a lab report for non-African American. You could be biracial and go down your African American side and you're not a candidate. Go down your non-African American side and you're automatically available. And so we started saying to people, ask questions. But the other thing I have to say is that the kidney risk index, Dr. Butler, there was a time, and this is just changing, where if you were a Black person that donated your kidney, you were automatically considered in the risk index, along with drug addicts, along with people with other comorbid conditions. Just being African American made you more at risk for being a donor. So we have some work to do. So thank you so much for starting.
Well, that was relevant. Thank you for sharing that. I do want to say that every Wednesday we are at the Nativity School of Harrisburg, and we have a Global Scholars Program, and you will be invited, and maybe we can get those young men to put on some white coats, because this is when they're receptive in that middle school year. So with that, let's call up our next doctor, Dr. Sharee Livingston.
Hello, how do you follow that? Boy, Dr. Butler, I'm like, I want to be like him when I grow up. I'm Dr. Sharee Livingston. I was actually born and raised here in the inner city projects of Harrisburg, so I feel like I am at home. I am amongst friends and family and colleagues, and I'm honored to be here. I am an obstetrician-gynecologist. I love women, I love people, I love humans, and I get to take care of people and humans from puberty all the way to menopause, and it gives me an amazing opportunity to make a difference. There we go. Here are some objectives. I won't bore you with my objectives, but my primary goal is to inform you of what I know about Black maternal health. That's the area where I was born and raised. My mom's here in the house. Give her a shout out, y'all. Yay, Nana. I do that for a reason. I am not anywhere of where I would be without my biggest cheerleader. So when we talk about Black maternal health, we have to level set with definitions. If a person was pregnant within 42 days of their death, we consider that a maternal mortality. And then that's further subdivided into pregnancy associated or pregnancy related death. Why am I talking about that? As an OBGYN doctor, I get to do robotic surgery and do robotic hysterectomies all day long. I get to deliver babies vaginally or C-section, and I see patients in the office. I write birth control pills for people who may not be interested in pregnancy. I tell couples and sometimes single people that they're pregnant. I do pap smears and breast exams and vaginal exams, and I do all of that. And I have an amazing time as an OBGYN physician. However, bad things happen. And I watched 2 women die after childbirth, and it changed everything for me. It changed my perspective. And I paused and said, why is this happening? Because when we were in med school, we weren't taught a lot of things. I was today years old when, as the young people say, when I found out that the B. Lynch stitch, which is a stitch that we put in the uterus when a woman's uterus won't contract down after she gives birth, it's a life-saving stitch. Dr. B. Lynch was Black. How did I go through St. Joseph's University in Philadelphia studying biology? How did I go to medical school in Philadelphia? Did a rigorous Penn State OBGYN residency, and those folks out there are amazing, no diss to them. And I just found out that Dr. B. Lynch was Black from Sierra Leone. That's not right. So when we talk about information, that's why I'm up here, so that we can recharge the information pathway so that we can work on prevention. And that is the key. Maternal mortality in the US. You don't have to be a statistician to know that this graph is abysmal. We are heading in the wrong direction as a highly resourced nation. We are amongst a few countries that have a rising maternal mortality rate. North Korea, Zimbabwe. Unfortunately, we are amongst a very small sector because most other countries have figured out how to improve maternal morbidity and mortality through doula care, through midwifery care, heck, increasing access to affordable health care. They figured it out. In a couple slides, we'll talk about the whys. And on the drive here from Lancaster, my daughters and I were talking about, how mommy always talks about asking, if somebody asks you a question or makes a statement, ask why 5 times. Black women are 3 to 4 times more likely to die in childbirth. Why? Because they have more chronic conditions, they're more obese. Why? Because they live in, I don't call them food deserts. This is America. We don't have food deserts. That's food apartheid. Food apartheid, when food, healthy food, is redirected from our neighborhoods. That's food apartheid. So then, okay, why? Why do they have higher blood pressure? Ask Arlene Geronimus, who wrote Weathering. It's an excellent book. My daughters will be reading it when they are done, reading whatever they're reading. It's an excellent book. Please take note. Arlene Geronimus talked about weathering, how chronic stressors like discrimination and systemic and structural racism lead to chronic conditions. There's a reason 50% of Black women, pregnant or not, have high blood pressure, hypertension. It's not because we eat too much salt. It's not because we don't know how to have discipline at the table. There's so many more factors. So as we get to the whys, I think I'm at number 3 or number 4. And why do we need to dissect the question and the statements and get to the whys? Because you can't fix problems unless you know exactly why they exist. So I told you, Black women are 3 to 4 times more likely to die in childbirth. 55 per 100,000 women, Black women. That's an unacceptable statistic. Now, birthing people are at risk for death just in general. That it is what it is. But it's these disparities. See, there's a difference between inequity and inequality. An example of an inequality is cardiovascular risk, heart risk are just naturally different for an 18-year-old boy versus a 68-year-old man. That's an inequality. That's natural. We can't do much about that, correct? And inequity is when there's a difference or a disparity that can be fixed but is left alone. That's unjust. For example, the prevalence of diabetes in Black communities, hypertension in Black communities, obesity in Black communities. So around 2018, the United States started measuring maternal mortality rates. That should concern everybody in this room. Like, wait a minute, we just started evaluating maternal mortality and morbidity. We had a suboptimal way of tracking it. Now we put a box on death certificates, and there's a box that says pregnant or not pregnant. And that we've gotten better at tracking and tracing the data. And so right around 2018, we developed better systems to evaluate maternal morbidity and mortality. Morbidity is, obviously, you know what mortality is, that's a death. Morbidity is a near-death experience. So hemorrhage, if I have a woman who gave birth and an hour later she's bleeding out and I have to give her a blood transfusion, or someone who experiences a pulmonary embolism like Serena Williams did, or Beyonce who had severe preeclampsia. All of these things are what we call morbid events. And for every one death, there are 100 morbid events. So the focus should lie on the morbidity, not just the mortality. So here in Pennsylvania, we did some evaluation of maternal mortality, and we reviewed the data between 2013 and 2018. There were 547 maternal deaths here in the state of Pennsylvania from 2013 to 2018. There was significant disparities in those deaths. So for example, white birthing people made up 70% of the births and 65% of the deaths. Black people made up 14% of the births and 23% of the deaths. You don't have to be a statistician to know and understand that's a disparity. And that's why I'm here. I'm up here, just like we all are, to focus on eliminating health disparities, specifically racial health disparities. I'll breeze through a little bit of them. So raise your hand if you've heard of the documentary Aftershock. Yeah, I would highly and strongly encourage, and it's okay if you haven't, I'd strongly encourage you to take the time to look at this documentary. Spike Lee's wife, Tanya Lee, she and Mrs. Eiselt, they worked on this Aftershock documentary, and it is about American and US maternal morbidity and mortality. And the face that you see up there is Shawnee Gibson. She and I were together a week ago in New York City. We were on Sirius XM together, and she and I are working on many things. We'll be in Alabama together next week. We're doing a lot of things where we're collaborating. See, one of the things that we as a community must learn is that working in silos gets us nowhere. I don't need any more people to invent their own organization and their nonprofit. Join a functional nonprofit. We have a nonprofit, Flow for the Love of Women, where our mission is to eliminate menstrual inequity. Join that. Like, if everybody keeps forming their own nonprofits, we are less effective. So anyway, I put this up here so that if you want to enjoy an amazing documentary about the US maternal mortality and morbidity, it's an excellent documentary. What's the reality? You know, we talked about the 5 whys. Why are people dying? Systemic and structural racism, I have no problem putting that as number 1. Because it's important to understand that the common denominator of racial health disparities is systemic and structural racism. Black people are not broken. We have birthed beautifully. When I finished my residency in Penn State Hershey in 2006, my husband said, he and I are both, you know, from Harrisburg, and we both had these huge families here in Harrisburg. And he's like, well, hon, if we live in Harrisburg, we're never going to be able to start a family. And he's right, because I have one of the biggest families in Harrisburg, and he has a big family, and they would be knocking at our door all the time. So he had this amazing idea for us to move to Lancaster, and there was a great job opportunity there. Well, Lancaster is the #1 home birth city in the state of Pennsylvania. Well, little did I know what I was walking into. Amish, wonderful folks, Mennonite, urban, you know, Lancaster has its city. I have Harrisburg folks that come up and see me in Lancaster. But one of the things that I noticed about being in Lancaster is the wonderful exposure to doulas and midwives. So from day one, I have worked with doulas and midwives, and everybody's now talking about doulas. Doulas are non-medical trained professionals that support birth. And remember, doulas and midwives predate doctors. So don't let us doctors tell y'all we're all that, because the reality is doulas and midwives predate doctors. Look, if you want to Google something, Google granny midwives. Actually, the first granny midwives were Black, and they birthed beautifully. So I had someone ask me when I was on Sirius XM last week, they said, Dr. Livingston, my goodness, these statistics are abysmal. They're terrible. Has this always been the case? I love when people ask me that. You know why? Because I love to answer with, we birth beautifully. We are scaring women, by the way. I've had patients that tell me, Dr. Livingston, I love you, but y'all are scaring us. Y'all are telling us all these horrible statistics, and we're afraid to get pregnant. We're afraid to birth. And I share with them that knowledge is important. Knowledge yields preventive care. That's how we're going to promote and advance preventive care and better health outcomes, by educating the community. And in addition to educating the community, listening to the community. See, we don't have all the answers. If you're looking for solutions, go to the communities that you're actually trying to help and fix. Ask them. They'll tell you. Black women will tell you how they can birth better. We do birth better, but keep in mind, once the oppressive regimes occurred here, when we were enslaved people, I don't use the word slave, it's enslaved people. We were beautiful people. Some of us were enslaved historically. And once those oppressive regimes began, we had absent maternal health care. And then after the absent maternal health care, Jim Crow laws came about, and care was diverted away from birthing Black people. And then we have the current day and age. So when you look on the screen there, implicit bias. Bias is the brain shortcut. Everybody has bias, right? I have a patient who walks in and they're like, oh, Dr. Livingston, I'm in a lot of pain. Before they say anything, see, we doctors are trained to exact bias and just really try to figure a diagnosis out just by looking at a patient. Well, you know, her lips look a little ashen gray. Maybe she's anemic. Oh, she's bleeding too much. Maybe she has fibroids. We're trained to do that. It's when implicit bias yields adverse health outcomes. So we all have bias, but it's when you see a patient who comes in and they're complaining of pain, and we know the data shows that Black women are less likely to have their pain treated, that you're like, oh, she's just drug seeking. Meanwhile, she has an ectopic pregnancy and they're calling me at 3 a.m. because she has an abdomen full of blood. We have to get better at listening to patients and trusting patients. I'll keep going just so that my friends up here can have their turn. So what's the impact of what's happening with Black maternal health? Like I said, there's fear, lack of trust, lower self-esteem, internalized racism. But let's talk about solutions, right? We know that there are many solutions. So I co-founded an organization, the Diversifying Doulas Initiative. And to date, we have provided over 300 birthing people of color with fully subsidized doula care. Doulas are expensive. They cost about $1,000 per interaction. Most doulas will engage and support their, they call them clients. Don't judge me. That's what doulas call their patients. I call them patients, they call them clients. But they engage them prenatally, during the birth, and then postpartum. Most maternal death occurs postpartum. 4 out of 5 postpartum deaths are preventable. 4 out of 5. So the initiatives like Diversifying Doula Initiative, those are solutions that we can exact so that we can lean on those. I can't do, as an OBGYN physician, I can't fix the maternal health crisis by myself. So what do? I stretch my arms and say, I need to build this perinatal workforce, make it stronger, get doulas on board, midwives on board, hospital administrators, nurses, doctors. That's how we're going to fix this problem. Looking within in the hospitals and the offices, looking without, engaging the community. I also have an organization, Patients Are Waiting. We have about 700 students in our catchment. We're currently 11 years old. Our mission is to eliminate health disparities by increasing diversity in medicine. If you look us up, patients, the letter R, waiting.com, we created that name for a reason. Patients are literally waiting for us to diversify medicine. Why? Studies show that if there's cultural congruence, patients are more likely to adhere to preventive care. They're more likely to adhere to their treatment regimens. I was on the radio this morning, we were talking about that, where if, and you know, ain't my fault that it's the case, but if a Black doctor says, you need to take this medication so that you can lower your blood pressure, address your diabetes. The study shows, great research that came out of Oakland, where they showed that patients are more likely to adhere. And it's the trust factor, right? When you have cultural congruence, you have similar lived experiences. And then in addition to that, we want to improve some of the other solutions. So for example, with Patients Are Waiting, we want to diversify medicine. Since the 1960s, the US Census Bureau tells us that the number of surgeons and doctors that identify as Black has remained stable at 5%. If we represent 12% of the population, why has that number remained unchanged? So Patients Are Waiting engages medical schools. We have a Pipeline Dreams program that we're currently in year 6 of, and we bring in about 80 students, and every Tuesday they work on a health disparities research project. Why? Because don't let people fool you. Doctors aren't smart. We're just folks that love math and science usually, have decided, we've decided to go into a lot of debt over 10 years, becoming, you know, Dr. X, Dr. Y, and Dr. Z. But there are a lot of potholes along the way. And there are students who look like me and look like Dr. Butler who say, I want to become a doctor. And the moment they get a C on the test, somebody's like, well, I don't think so. You know, this wasn't meant for you. Meanwhile, back at the ranch, you know, other students, you know, get a C and people are like, you can do it, you can do it, you got this. That's what our students need. And that's what Patients Are Waiting does. We pour gasoline. We were on last night. Last night we were doing week 6 of 12. Like I said, every Tuesday night, we get all 80 of these students. We talk, they're working on a respective health disparities research project, and we breathe life into their dreams. When we talk about MCAT scores, which is a test that we take in order to gain entry into medical school, I had students last night say to me, Dr. Livingston, but what if I get a low grade on the MCAT? I said, pause right there. When you score any grade on a test, and my daughters are back there, cover your ears, I need you to get good grades. When you score whatever grade on a test, that is a snapshot in that one moment in time. It is not reflective of who you are and what you can do. And that's what our students need to be told. That's why with Patients Are Waiting, we have worked tirelessly to breathe life into the dreams of young folks who look like us. So I'm going to leave on that slide because solutions are where I like to focus my energy. I know some of the stats are heavy, but we can do this. Thank y'all.
She just said, silence your phones. Make sure you silence your phones. Go ahead. But I just want to say, really, this has been fantastic. I am like brimming with pride. I'm just telling you, you're just wonderful. But go ahead. Go ahead.
Good evening. The 2 presentations you've heard, just truly outstanding. What I'm going to talk about, what is our role as patients in this process? Because it's truly a partnership. And I contend half of the solution of the problem is with the patient. And if they don't bring all of their issues to the table so the physician knows what's going on, if they don't fully participate in the exercise, then our healthcare system will continue to deteriorate. I'm a 33-year prostate cancer survivor, and I got involved in advocacy shortly after my treatment. And so my role is trying to get men to think more about their health care. We men do not advocate for our health. You know, women are from Venus and men are from Mars. My most receptive audience for men's health are females. And that lies one of the problems. We do not advocate for our health. You saw previously some statistics. Here are some more. I'm not gonna, you can read them for yourself. But as far as prostate cancer, it's a devastating and kills a lot of Americans. And you notice there in red that we lose more men in prostate cancer in 2 years than we did in the 10-year Vietnam War. And recently you've heard of celebrities who have had problems with prostate cancer, including the King of England. This is just showing the incident rate of prostate cancer in Pennsylvania. There'll be 13,000 cases this year, and 1,400 men will die from it. I'm up on the Capitol many times promoting men's health. In Pennsylvania, we allocate zero money for men's health initiatives. And why is that? It's because we do not advocate for our health. And the people I'm talking to are men, so you would think it would be a no-brainer. But that's a fact of life. Pennsylvania Assembly allocates zero money for men's health activities. So I say advocacy is the key. For example, I'm chairman of the Pennsylvania Prostate Cancer Coalition. My partner is Pat Murphy, helping Murphy, who's founder and president of the Breast Cancer Coalition. The first bill that our governor signed was the Act 1 of 2023, which was the first of a kind law in the nation where it requires insurers to provide coverage for breast cancer and ovarian cancer screening for high-risk women. And that's because when Pat goes on Capitol Hill, she has 100 screaming women with her, and people pay at least 100, and a couple of them are here in the room. People pay attention. When I go up on the hill, it's me and one other person, and although we make a lot of noise, it just doesn't have the same effect. Let me tell you my story. My wife saved my life, Lois. Okay. We've been married 62 years. Yeah. And I tell you, Joyce, the first 60 years are the hardest. Huh? In 1991, I had retired from the military and I was working as the human resources director for the American Bar Association. They have their headquarters in Chicago. My wife said, you need to go see the family doctor. And I had not seen our family physician. I was an active private pilot at that time, and to keep your pilot license, you have to get a flight physical every 3 years, and I was doing it, but I had not seen our local doctor. I went to the local doctor to have an examination, and he introduced a new test called PSA. Okay, the number came back, and it was 10. Well, in those days, 4 was a magic number. There is no magic number now, but if a man had a PSA number of 4 or higher, then that was suspect, and you probably were referred to a specialist. If it was under 4, you're okay. My number was 10. I was 55 years old, African-American, and this PSA at 10. So I went to a urologist. Well, as you know, we talked about stovepiking and silo effects. I went to a urologist. He's a surgeon, and that's what his concentration is. But bless this guy, they did a biopsy, discovered the cancer. gave it a Gleason score at 7, and we're not going to go on that, but the scale from 1 to 10, and mine was 7. So I was in a little trouble. My urologist says, I want you to go to a radiologist because they look at the world a lot differently than I do. I want you to go to an oncologist because they look at all kinds of cancers. And I want you to go to Mayo Clinic because they're doing a lot of surgery on cancer there. Now I'm in Chicago. There's some fine facilities and hospitals and specialists in Chicago. Why should I travel 5 hours away to Mayo Clinic to have somebody else look at it? But that's what I did. And I fell in love with Mayo Clinic and had surgery at Mayo Clinic in 1991. And I knew I was at the right place because there was a sheik from the Middle East who had his private 747 parked at Rochester Airport. I didn't know you could have a private 747. He had taken over the top floor of the Ramada Inn and had his staff there, and he was 2 doors down from me, and he had a bodyguard sitting outside the door. So I said, if this is good enough for the sheik, surely Mayo Clinic is good enough for me. I had an outstanding surgeon who was very aggressive and removed my prostate. And in that surgery, they always look at the lymph nodes first because that's where the prostate cancer goes when it leaves the prostate. They didn't find anything in the lymph nodes, didn't find anything in the prostate bed. But he said, there might be some microscopic cancers. I didn't see. I want you to go on hormonal therapy also. So I had 2 procedures, surgery and a series of hormonal therapy shots. And I've been cancer-free for 33 years. Okay? Okay. And not only that, being retired military, we have a health plan called TRICARE for Life, and that paid for most of the expenses. So as I got into advocacy, I found out that my experience was the exception, not the rule. And my experience should be the rule with the healthcare in America. And so we've been working for a long time trying to improve that journey for Americans. Let me tell you a war story. My second tour in Vietnam, I was an advisor to the Vietnamese Popular Forces and Regional Forces. This is the local forces south of Saigon. One day, my counterpart told me that he had fired his doctor. And I said, why? And he said, because I got sick. And I didn't understand that. In Eastern medicine, you go to the doctor to stay well, to stay in balance. It's a yin-yang principle. In Western medicine, most cases, the best the doctor can do is make you unsick. We never get to the balance and the whole sphere of what makes people healthy. And that's where we need to go. We don't have a healthcare system. Now we realize now you're talking, I'm a layman, I'm not a professional medical person, but in our estimation, many of us believe we don't have a healthcare system in America. We have a sick care system in America that's driven by fee for service. The professionals get paid for diagnosing and treatment. There's not much money for prevention, although we all agree that prevention is the key. And who's going to change that around? You and I are going to change that around. These people are well-trained, have many tools, but unless they have the support of the population and advocacy to support what they want to do, it's not going to turn this elephant of reactive medicine around, which is what we have. We need a value-based healthcare system. Our system is based on, and I'm involved with Penn State and WellSpan and some other health activities. And our progress in those areas is based on how many more beds we created, how many more practices we get under our wing. It's not based on how healthy our patients are. And that should be the driving force in the healthcare system. Not the financial aspect of it, but the health of our citizens. And you and I are going to have to turn that elephant around that sits in the room. It's hard to see this slide, but what it shows, as it's been pointed out, you see above all those lines there are industrial nations and the mortality tables. And the red line is the mortality table for the US. We don't live as long as many of our partners in other countries. And yet we spend tons and tons of money on medicine. I say if we're going to stay number one in the world, we have to be healthy and we have to be educated. And we're spending tons of money in both of these areas and not getting a good return on an investment, largely based on what the previous presenters talked about. Well, quickly, this is my organization, Pennsylvania Prostate Cancer Coalition. We are men and women. I like to say young, but not too many young people in it, young and old, who try to make men aware of the need for going to the doctor when you're well, not when you're sick. I tell them, you take your car and you get the oil change, get the annual inspection, not because the car is sick, but because it's good preventive maintenance. And we need to have the same emphasis on good preventive medicine. And we need to help these people by giving them the resources. And so we are doing less reactive medicine and proactive medicine. Don't fear the finger is our slogan for prostate cancer awareness. This is a simple test where the doctor, male, female, sticks his or her index finger in your rectum and can feel a portion of the prostate through the rectum wall. It will not tell them whether or not you have cancer or not, but it's an indication of the health of the prostate and can aid them as they try to find other tools to diagnose your disease. The good news in prostate cancer is that we find it early now. The bad news is that there is no gold standard. And so what happens is it's like the TV show Curtain 1, 2, or 3. You have this option, that option, or another option. And that's not what the patient is thinking of when they go see the specialist. They expect them to tell them what treatment is best for them. And many times the patient has to figure it out for themselves. Just one last picture is, people say, well, why are you in this work for so passionately and for so many years? These are my grandchildren. This picture was taken a couple of years ago. The female there now is majoring in chemical engineering at North Carolina A&T. And her brother just made the state choir in Virginia. He's in junior high school. But if it hadn't been for my wife saving my life, I would not be here today enjoying my grandchildren. That's what I tell men that, especially African-American men, just your presence, just being who you are and the experiences you've had, regardless of what your title or your education is a powerful force in our community. And we see so few men my age in the community. I'll be 88 years old come August, okay? I'm still trying to figure out what I'm going to do when I grow up. Unfortunately, many of my contemporaries are no longer here. And so we work very hard trying to raise the health standards in our community. Thank you.
Beautiful. I mean, this has been a panel already, right? But as we know, right, we have the physical, and we've heard from 2 expert doctors, and we've heard from a patient, the patient perspective, right? And thank you, Lois, you're a wonderful lady. But now we've got to also incorporate the one thing that's missing here, and the next time I'm going to have this is spiritual, but at least we got to get to mental and emotional, because that's all a part of what we are as well. So Ronnessa, yeah. And she's young. Would you come forward?
Can you hear me? Okay. Good evening. My name is Ronnessa Edwards. I'm with the Pennsylvania Human Relations Commission. I currently investigate or supervise investigations of civil rights complaints. I'm a recent graduate with my master's in clinical psychology. So I have a background in mental health. And what I'm doing now is advocating for to highlight the intersection of social justice and mental health. As an investigator and as supervisor of investigators, we come across complaints of race-based discrimination, right? Individuals lose their jobs and they believe it's due to their race. Individuals are evicted from their homes or denied loans and things, and they believe it's due to their race. And so they file a complaint with our agency and we investigate that complaint free of charge. But what I was seeing is the firsthand effects, mental health effects of being discriminated against, firsthand discrimination, right? We don't talk about the toll that being discriminated against takes on the mental health, right? We second guess ourselves. It's part of our identity. Our race is our identity, our skin color, our hair, those characteristics. And when you are treated differently because of those characteristics, you start to second guess who you are. And so what we're seeing now is that individuals are walking around with symptoms of what we call PTSD, right? Hypervigilance, irritability, isolation, depression, flashbacks even. And so the mental health community is looking at it as PTSD, but there's an error there because race-based discrimination is ongoing. It is continuous. And so there's a term, continuous traumatic stress disorder, which I believe falls under race-based, or race-based discrimination falls under continuous stress disorder. And it was a term that was developed in the 1980s in South Africa, apartheid era South Africa, where they studied those who were undergoing political violence, and they were trying to treat them with the PTSD model. But they realized that it wasn't working because the event hadn't stopped. It was ongoing. And so the mental health professionals had to try and institute new techniques and new interventions to address the ongoing threat of violence and the real threat of violence, which still isn't being recognized in today's mental health model. As I stated, I recently graduated. As I studied the clinical psychology, the American Psychological Association, mental health companies admitted that the model of the patient is based on a white person. It's a Eurocentric model. Black and brown individuals are underrepresented in the research when it comes to interventions to address trauma, but yet they're more likely to experience trauma, specifically due to the structural racism that we talked about, individual racism, environmental racism that my counterparts just spoke about. These things are real threats to our health. It affects the social determinants of health. And so I believe that mental health professionals and researchers, even managed care companies, should invest and look into the disparities that exist because structural racism is still alive and present today. Some of the, Dr. Butler talked about epigenetics. So on top of experiencing direct trauma, we also have what we call epigenetics, where our genes can be expressed differently based on the trauma that's passed down generationally, right? So we talk about, when we talk about slavery and the effects of slavery, and people will say, well, that was so long ago, but it is still realized and still seen in our DNA to the extent that we might be afraid of those in authority or systems, right? And not understand why. It's not only because of the slavery that our ancestors went through, but also the structural racism that's still in place that ignite or allow those genes to be expressed in how we behave. It institutes our fight or flight response or fawn response, right? And a lot of these, a lot of Black individuals are walking around and don't understand why they're upset, why they're so irritable, why when they're in employment and a supervisor is sort of micromanaging them, why they have such an adverse reaction to that and they can't keep a job, right? And then when we investigate complaints at PHRC and the respondent says, well, this person was, they had an attitude or they were being aggressive. Those are those dog whistles, those code words for that institutional or systemic racism there. Those supervisors, the employers, have that implicit bias that Dr. Livingston talked about, where internally we all have bias, right? media portrayal, our exposure to other individuals or lack thereof is what creates those biases. And so you may not even know that you have this negative feeling towards someone who looks a certain way because of the messages that you've received. It's our brain's way of protecting itself from overstimulation or overinformation. It's pruning, so it's organic, but when you deny it because you're defensive, then you fail to evaluate that and to institute practices to prevent yourself from treating someone disproportionately or adversely. Structural racism is the reason why Black and brown folks are denied or have been removed from mental health resources. And again, the mental health organizations, they recognize that, and we're now trying to include Black and brown individuals in our studies. And structural racism also impacts the intersectionality, right? So when you hold multiple identities, when you have your Black person, but you're also a member of the LGBTQIA community or a woman in our patriarchal society, right? So now there's compounded impacts of trauma that mess with your mental health and impact your mental wellness. And so we need to, I think we need to really look at that as far as talking about it more. Right? So in our Black communities, there's a stigma attached to mental health. We don't want to be labeled as crazy, or we don't want our child to have another label to be another stack against them, right? So we see parents that are fearful of getting their child evaluated if they're displaying developmental delays, because they don't want another stack or another strike against them. But what we need to do is destigmatize that, because without that diagnosis, then you're not able to connect yourself with the resources or even know to ask for it, right? And I think that that is an injustice, and it creates increased substance abuse, because we grow up, we have these undiagnosed mental health disorders, and some people resort to self-medication. And so these are all things that are impacted by structural racism. And so when we talk about the mental health crisis, Joyce had asked, are we in a mental health crisis? I would say yes, but not because of COVID. The mental health crisis for Black individuals existed before COVID, because we are constantly living in structural racism and constantly having to prove ourselves, constantly having to work twice as hard, feel less than, be rejected at different odds and ends. And so I do like that we are now bringing it to the forefront and we're having these buzzwords, but I'm cautious to even say that, because oftentimes these words are, the fanfare comes from when the affliction is on white individuals. What I mean by that is, I look at the drug epidemic. When the drug epidemic was in the Black and brown communities, it was met with a criminal justice model. As soon as white individuals or suburban neighborhoods were inflicted with the opioid crisis, which came from the fact that there were mental or medical disparities in the medical field, right? Because Black people weren't seen as feeling pain, so they weren't prescribed the opioid prescriptions at the same rate. But as soon as the heroin addiction and the opioid epidemic was in the suburban areas, that's when we want to treat it with a mental health model. We have diversion programs to prevent them from going to jails. When the prisons are full of individuals who just needed treatment, when they closed down the medical and the mental health facilities, the prisons were filled. And I used to work at SCI Graterford, State Correctional Institute at Graterford, and I would see that. A lot of these individuals just didn't have that intervention, was not able to be connected to the mental health or the therapy, right? Because in our neighborhoods or in the Black and brown neighborhoods, there aren't many mental health facilities. There might be one community organization, and it's overfilled. I did my internship at a place called Greater Philadelphia Health Action. And the waiting list from intake to ongoing services was so long and so sad that I felt the need to take on clients that I wasn't even qualified at the time to take on, because I knew how long it was going to take for them to receive the treatment that they needed. And so we need to increase our Black mental health professionals. We need to fund our nonprofit organizations that are providing these mental health therapists. And we need to ensure that we can, or fight for equitable access to culturally competent mental health services. Because again, you have a therapist in the seat, and they're not speaking the language or they don't understand the stereotypes, or they don't understand the mistrust that patient's coming to. They're not able to make that connection in that way. or they're not able to understand the afflictions that that person is going through. And so, you know, we're fighting for increased funding for these nonprofits, increased Black representation as mental health therapy. And we want to also provide legislation or fight for legislation that breaks down the barriers, the socioeconomic barriers to being connected to mental health resources, to being insured, right? Not everyone has a job that can provide them the insurance that they need to get the therapy. And that's if the mental health therapy agency accepts that insurance. So there's so many barriers that prevent Black and brown individuals from receiving equitable, culturally competent mental health resources. And I think we need to fight for legislation to make poverty and structural racism a pandemic so that we can get these think tanks together to really, thank you, to really break down the system. We need to dismantle systemic racism. It affects too much and people are dying. But because it's not a certain hue, it's not considered or it's ignored. And it affects my mental to even think about that. So talked about that, yes. I also think individually that we have gone away from a few of the African customs that would help us to deal with our mental health issues internally as Black folks, such as storytelling, right? We need to pass down these stories of what we've gone through and be open and honest about what we're going through so that the younger generation knows that it's not something to hide from, that they're feeling this pain or they're feeling sad or they don't feel like getting up. Why? What can they do about that? But because we stopped telling stories because that's not my child, I'm not worried about it. It's perpetuating, and the kids are out there, and it's the youth, the young people are dealing with so much right now. It's especially, I know I'm from Philadelphia, the gun violence in Philadelphia, which is directly associated to the poverty, because it's so overwhelming. But I think we need to get back to storytelling. We need to connect with healthy family members. A lot of our families are separated, and that's what COVID also did, that isolated us. But we need to get back with our family members, check on each other, talk with one another, be supports, show unconditional love to one another. Of course, arts and crafts, those are some interventions that we can use to address or overcome some of the symptoms that you have when you're dealing with grief, depression, things like that. Basically, what we do as Black folks, right? We know how to dance. We know how to sing. Black culture is pop culture. And I think we need to get back into doing more of that to heal ourselves. And then also to make songs maybe about advocating for equitable access to mental health. It needs to be the popular thing. It needs to be the cool thing. We need to be able to talk to the young folks. We need to be able to speak their language. And that goes back to also being culturally competent. And so what do I think people can do? I think that they can, like I said, advocate for legislation or talk to your community, your health centers, the managed care providers, find out what, talk to the people, find out what the lived experiences of the people are, to find out other ways that you can help, and really just continue to talk about it, continue to put our health in the forefront of everyone so that people understand, so that they can't deny what's going on, so that we can get the attention that we need to provide equitable access to culturally competent mental health. So thank you.
Very much, Ronnessa. We have had some information shared today. We really have. And I'm a journalist, so I could question them a lot right now. Right? I've got a load of questions, but I'm going to turn it over to you. So get your thinking caps on, right? I know you have questions and you may have a comment. You want to say anything else? Because you're an expert too. I know you're. Okay, go ahead. Go ahead there. She's good, Phyllis. Go right ahead, Phyllis.
Well, first of all,
but
let's see, is it on?
Yep, he'll turn it on. Don't worry about it.
Hello?
Yep. Yeah.
First of all, I want to thank Dr. I want to thank you, Joyce, for being the springboard for this, because discomfort can move us to action. It's okay if some people in this room are uncomfortable, because this is how things change. And I also want to thank Highmark for just sponsoring this because
Yeah, Highmark.
yeah,
Thank you.
we always have to
They're
thank our
making it
sponsor
happen.
because
Yep.
this is
Yep.
the springboard for change. We have to have these discussions. We have to be willing to have them. But I'm going to give other people the mic, but I just want to say that basically patients advocating for themselves is so important. The storytelling, I grew up in the segregated South, and I can tell you storytelling was a huge part of our story, my family history, of how we stayed connected, of how we survived a culture that was literally killing us. And I could show you trees in my town in the South where some of my ancestors were hung. It's powerful, but I think that what happens is we start to look at how we can be a part of the solution and not part of the problem. And I want to thank Dr. Livingston because, this issue of maternal health, there's a lot written about it, but Black women are dying, Black and brown women are dying. Women are adversely affected, but when you've got somebody that looks like you, they listen to you. And of course, Dr. Butler and I, work closely together because we are really trying to encourage kidney transplants in the community, not just the communities of color. But just want to thank all of you guys for being here. And I have
She's turned into the MC, but there's a question.
yeah, I'm like, who's?
There you go. She'll do it. Thank you. Thank you, Phyllis. Thank you.
My question is for Mr. Williams. At what age did you, I'm sorry to ask to have everyone know your age, but what you already said it. What age did you get tested for prostate cancer, and did you have any symptoms, or what caused you to go to the doctors to get tested?
Great question. I was diagnosed at age 55. The current guidelines is that men 40 and older should have a conversation with their health provider about the pros and cons of prostate health. Most cancers can be cured in the early stages. The early stages are before there's any symptoms, and that we don't hear about. Men tell me, well, I'm not stupid. If I get sick, I'll go to the doctor. Well, first of all, they don't go to the doctor when they have symptoms. They go when they're very, very sick. But because we don't push prevention as we should, we're always catching up with our health problems. So we state that men 40 and older should start going to the doctor, having examinations, knowing what their numbers are. The key for the health professional many times is having a baseline number and then tracking that number with further examinations. And tracking those numbers will tell the health professional things before there's a diagnosis or before physical examination. And so we try to promote why going early, getting baseline numbers, not only for prostate cancer, but for prostate, but for cholesterol and blood. You should have those numbers available and know what those numbers are and discuss it with your health professional.
And truly, I think you're hearing that there's no reason why a 20-year-old Black male shouldn't be going every year for a checkup. You don't have to be sick. You just go.
Yeah, in our society, females get a kind of an
Yeah.
orientation on going to the doctor as they mature. The good Lord had enough sense to have them have our babies, because if it was us to a male, the species would not be on planet Earth. Okay, and good or bad, usually the female becomes a healthcare provider in their family. So there's a liaison between medicine and women. And they understand inspection of the body, monthly examinations, but we men don't have that conversation with our male sons, and so we don't go to the doctors until we're sick. We pride ourselves in not getting sick and not missing a day of work, and I don't like to go to hospitals, and that mentality is killing us early.
Thank you.
You had another
wanted to say
question?
I
Go
want to
ahead.
agree with you. I have an uncle who is, I think it's in stage 4 prostate cancer now. And a young man around my age, I'm 40, so that's why I asked, because I was kind of concerned about it with my uncle. And then a young man around my age who is now stage 2 cancer. So I just wanted to ask you about your experience in the age range, and do you think it would be a good idea to go even younger than 40 to get checked out and to find out, what your levels are?
Another thing in that area, men who have been diagnosed and treated for prostate cancer go in the closet. We have a program called Spare Parts, trying to get men who have been diagnosed with prostate cancer to come out of the closet and speak to the contemporaries about their experience. Because many times telling their story has more of a positive effect with the audience than hearing evidence-based information from the professionals. Women don't have that problem. Women who's diagnosed with breast cancer finds herself in a family of support in many areas. We men don't find ourselves in that area. So we need to help each other by telling our story.
I agree. Thank you.
Any other questions?
Very important, and it is you now know you have a family history.
Yes.
So that in itself should drive you and all the men in your family to say, we need to start getting tested and start getting tested early and share that with your health.
Definitely. Thank you. That's something that's been bothering me or concerning me. And the men in my family we don't go to the doctors, or we don't get mental health checks, or we don't let doctors
So if you leave with
finger.
anything else, nothing else tonight, leave with that in your spirit. You must bother someone to get them to the doctor. You must also have an open heart to go to the doctor once a year, get checked up. Okay? So yes,
ma'am.
mama.
Yes, ma'am. Yes, mama. Thank you.
Yep. Thank you for that. Thank you, though. Any other questions? I know you guys have comments or questions. So yes, over on this side. Okay, whoever was first. We don't want to cause a fight. We want peace. Peace in the world. Close to your mouth. Just make sure you play close.
I want to be okay. I wanted to comment on something that the last young lady said about storytelling and those types of things. There are things within our culture that we have inherited as men from the storytelling. And some of that storytelling is how easy it is to lose your man card when you're whimpering about things. If you get hurt in practice, walk it off. There are things that are subconsciously given to us outside of the framework of which we're talking about. And so sometimes it's a matter of survival. Other times it's a matter of like, okay, now that I have my own family, my dad never went to the doctor. He always complained about the pricing. You have all these things that go into your head. So I'm wondering, what like your feedback, what do you think? Maybe some of the storytelling has to change so that, it's inclusive of that. Because I think everybody in the room has been touched in some way by someone in their life with cancer. And I know for me, I'm a survivor from when I was in the military, but if I hadn't been sick for all those years, I wouldn't be conscious of it. It would be second and third thoughts for me. And so as a grandfather of 7 kids and a father of 3 sons, it's vital for me for my kids to know their grandfather had prostate cancer on both sides and all that, but it's not natural. And I don't know how many men in here went through that, but culturally, it is not looked upon in our generation for baby boomers to even think about the doctors, but it must be the last resort if you're uncomfortable enough. Now, we all know that's not the way it should be, but it is what it is. And my question would be, what do you think about different ways of minimizing that through this either storytelling? We're writing songs, we're doing all kinds of cool stuff in these last several decades, but how much is touched upon about, hey, you're more of a man if you take care of this part of your business?
But go ahead.
I'm glad you brought that up. I think when you know better, you do better. And I think that we are now seeing Black men cry. We're now seeing Black men say, ouch. And we're now seeing the vulnerabilities of Black men and highlighting, Black mental health. And that's why there is a push to have more Black mental health professionals, Black male mental health professionals specifically. But it's all about, I think, talking and embracing one another and understanding the humanity in one another to say, you know what, in my day, it wasn't okay to talk about these proclivities or my illnesses, but this is going to save your life. Exactly. Because I'd rather talk about it than you die because we were silent. And so I just think we just need to continue to have events like this. We need to continue to have celebrities and people that Black individuals trust talk about what they're going through so that we can break that stigma of suffering in silence.
And we really do need to tell the stories. And I'll share something with you right now. I once had a brother who was 38 years old playing basketball and dropped dead. So, and you wouldn't have thought anything was wrong with him. Handsome, strong, playing basketball. So that's why you need to go and check out what is going on, even if you don't see it. All right. Yes, go ahead.
I wanted to bring up a comment. We'll make a comment.
Close to your mouth.
Oh, I'm sorry. Can you hear me?
Yes,
All
beautiful.
right. So besides these young ladies right here, I may be the youngest adult in the room. And we talk about telling stories, okay? Usually our stories are supposed to come from our elders and are passed down to us. What I'm seeing is a disconnect. We don't have those elders that are passing the stories down to us. I don't know if more of the community feeling as though we don't want to listen or we don't want to hear what you guys have to say, but the reality is we do. Personally, myself, from watching and listening to my elders, I was able to catch my diagnosis much earlier with thyroid disease. I had family members pass, but when we heard about their passing, it was more so the issues with the heart. Well, how did it get there is what I wanted to know. I had to advocate for myself constantly in order to get a specialist to actually provide me a test, because I was actually at this time, as my advocacy was diagnosed with schizophrenia, because the doctors could not find out why I kept saying I was feeling this flutter in my chest. And they kept saying, well, there's no flutter. We ran every test. We did everything we're supposed to do. And they literally put on the paperwork that I was schizophrenic because they could not figure out what was wrong with me. But I continued to advocate, and I got to a specialist, and the specialist said, yes, you have a thyroid issue and you caught it early enough. I was put on medication for about a year. After that year, my tests came back. Everything's been great since.
Right.
It's been 4 years.
That's beautiful. But sharing those stories like that are important. But I'll tell you, you ask, why aren't we storytelling? And I'll bring this up. Again, the Black church used to be a place that we connected. Now it's gone, right? I mean, or it's, no, but I'm just saying, okay. We're losing the places that we used to come together for support. Well, I mean, whether you believe in God or not, it was there and you met with your friends and your family and it was a root in your life. We've lost that root. Go ahead.
Yeah, I would just add, my grandfather, he's 93 years old. He grew up in the Deep South, and his stories are those that are filled with the Tuskegee experiment. Henrietta Lacks. Yeah. She can tell you stories about how Black slaves were used as experiments for the pioneers of OB-GYN. So I'll be very careful to listen to those stories, because in general, they may lead you away from coming to the doctor. My grandfather often told me, don't cry, don't show emotion, don't show tears. And he only goes to the doctor. Even me, I became a doctor and I still had trouble trying to tell him what to do. And it's inbred into our culture. So even if they tell the stories, we're telling you to go to the doctor, whether the story that they have is positive or not, because I can guarantee you in his community, the experiences were not positive at all. And I think faces like mine and diverse faces are changing that in medicine.
Anyone else?
I do.
All right, go ahead. I'm not going to cut this off, but we are moving over time but this is important. So the microphone's right there.
I don't need it.
No, you do. We're recording it. We're recording. Close to your mouth.
In our community, we do not tell the story of health issues. We brush it under the carpet. So there are many diagnoses out there that our parents, grandparents, relatives will not share. In my family, I am a breast cancer survivor, but there are 8 of us that have had breast cancer, and each one of us have had a different type. I have 33 first cousins on one side, and I come from a very large family. But I also wanted to ask about the doulas. Now you're saying that it costs like $1,000. So does the insurance pay for this, or how does one acquire a doula? I do have a friend who's retired as a doula, but I would like to know, in as far as the education for a doula, what's the time span, and probably, how much does it cost, that we could advocate for that?
So doulas are trained non-medical birth support people. But here's the caveat. You can have any type of doula. You can have hospice doulas, birth doulas, postpartum doulas. And I'll tell you why doulas are now expensive. Now, keep in mind, when I was speaking, I said doulas and midwives predate doctors. So the care that was exacted upon birthing people was performed by doulas and midwives. What's made them expensive now is that I, as an OBGYN physician, spend 15 minutes with my patients because that's all the time that I have. So I'm expected to do a GYN annual exam, a breast exam, pelvic exam, do a digital exam and ensure that ovarian cancer isn't there, all in 15 minutes. Doulas spend 6 to 11 times more time with patients than we do. So that $1,000 I'm a doctor who loves doulas and started a very large organization. I don't think that's enough, to be quite frank. And so fortunately, as of February 1st here in Pennsylvania, doulas can be reimbursed through Medicaid. So there are many pathways that doulas can get paid. Medicaid, their own private practices, organizations like DDI, like I have, we pay our doulas $1,000, but we are a grant-funded organization. And so depending on which pathway they're following, some doulas like UPMC McGee out in Pittsburgh, they have a birth doulas program. Right now, 6 to 8 p.m. tonight, we're training a new cohort of doulas, and the cohort is all Black. So we're being very intentional. Look us up, the Diversifying Doula Initiative. But I like that you asked about doulas, because the key to preventive care is building your tribe, building your healthcare tribe, so that you have that level of advocacy both inside and outside of the hospital and the clinic setting.
Thank you.
So maybe we have time for one additional question. If anyone has a burning issue that has not been tackled. Okay, there you go, our final question.
I just want to make one comment, because we had an excellent panel that painted a very vivid picture of an immense problem. What I want to say is that remember that the ocean is made of many, many drops, and we have drops here, and we need to accumulate more. So the problem looks very steep on a slippery slope, but I think if we coalesce and begin to work together, begin to listen to each other, I think we can do that. If not for us, then for our children.
There you go.
For our grandchildren. And you were talking about teaching our young. I'm a retired pediatrician. My cardiologist was a former patient of mine. So I firmly believe that the young is the natural resource that we must focus on, because they will take care of us when they're older, and they will take care of the rest of the mess that we left. Thank you very much, folks.
Thank you for that. Thank you.